Hi, I'm Tommy Thompson, and I work at the Wisconsin Women's Health Foundation. And unfortunately, I'm the fill-in today. My mother isn't feeling well, so sorry about that. And I feel doubly guilty because I think I am probably the one that gave her the illness. So that's what you get for working with your mother. But I do appreciate everyone being here today, and we are very excited about today's topic. It is the Wisconsin Women's Health Foundation's 6th annual dialogue, and it's the Obesity in Women, the Generational Impact. For 15 years, the Wisconsin Women's Health Foundation has been committed to improving the health and lives of women and their families through outreach programs, focusing on education and disease prevention, connecting women to resources, producing the most up-to-date resources, and funding women's health research. Our work is collaborative and very, very rewarding. We are pleased to have so many of you here today to discuss this important topic. During the last 15 years, the prevalence of obesity in women has doubled. As a result, we are seeing increases in diabetes, cardiovascular disease, hypertension, cancer, and prenatal complications. Obesity in women is a critical issue for our Dane County community, the state of Wisconsin, and our nation. It's wonderful to see so many others here today who are also concerned, want to know more, and see how they can address this issue. This dialogue is a great example of partnership in action. Partnership between healthcare, government, research, business, educators, and nonprofit organizations. Through collaboration, we can develop innovative solutions and strategies to prevent and treat obesity, ultimately benefiting families, schools, employers, and our entire community. I want to give a special thanks to our major sponsors, Centene Corporation, Dean and St. Mary's Hospitals, Meritor Health Services, WPS Health Insurance. And I also want to thank our supporters and partners, Delta Dental, UW Health, UW Department of Obstetrics and Gynecology, Group Health Cooperative, Summit Credit Union, and the YMCA of Dane County. So thank you very much. Today's moderator is a true friend to the foundation, Dr. Laurel Rice. She serves as the chair of obstetrics and gynecology at the University of Wisconsin School of Medicine and Public Health. She is nationally recognized as an expert in the care of women with gynecological malignancies. She serves in leadership positions of many national organizations. Recently, she was appointed Director, Division of Gynecological Oncology, American Board of Obstetrics and Gynecology, as well as a representative for the American Board of Obstetrics and Gynecology. She is also an editor of the Journal in Gynecologic Oncology. That's a lot of gynecological and oncology. That's a bit of a tongue twister. We are the most appreciative for Laurel's generous time, participation, and leadership she has dedicated to this program. She's a very busy woman, and she has given a lot of time, so thank you very much. I also want to take a moment to quickly thank our volunteer Dialogue Advisory Committee, who has helped us plan and organize today's event. Doctors Tara LaRoe and Cynthia Anderson from the University of Wisconsin School of Medicine and Public Health, Susan Swenson, a dietitian from Access Community Health Centers, and Sue Richards, a parish health outreach nurse from our office at the Wisconsin Women's Health Foundation. Thank you guys very much. I'm looking forward to hearing the dialogue today, so that is a foundation we, and I'm sure all of you here today, can do our part to address this issue head on. So let's get started. Please help me welcome today's moderator, Dr. Laurel Rice.
Well, good morning. I have to say I'm honored to be here, and I want to thank Tommy for that generous introduction. It is a dream for the Department of Obstetrics and Gynecology at UW to partner with the Wisconsin Women's Health Foundation. We have the same mission: improve the health and quality of life for women in the state of Wisconsin. When it comes to partnering and team formation, I don't think there's a topic more worthy than obesity. It is an epidemic. 42% of our moms who deliver from this department are obese. hypertension, diabetes, the downstream effect of obesity is huge. And it's not just pregnant women. I am a cancer surgeon for women, and we know that women with endometrial cancer are more likely to die of their disease if they're obese. Today, we're here to strategize about ways to positively impact this problem. And I am wildly enthusiastic about our panel. This is going to be a fabulous morning. Now, I have received very explicit instructions from Lizette about housekeeping. God bless her, that woman is so organized. I'm loving this. Yeah. So we're going to start with a 10-minute presentation by each panelist. And at the end of that session, we will have an interactive dialogue. That's what this is, a dialogue. We're not here to lecture you. You have something to contribute to this experience. There are going to be yellow cards floating around. We want you to write the questions down. This is part of it. You're going to direct the conversation. Our volunteers will collect those. After the interactive discussion, we're going to have a networking session where we're going to break into 3 groups and really think about 3 of the most important messages that have come out of the work that we're going to do in the next 2 hours. Start building those networks, building those teams to attack this problem. And I think we should get started. Now, we're very fortunate. Our first panelist is Dr. Michael O'Grady. He was recently named the president of the West Policy Center in Washington, D.C. 24 years experience in the area of policy and research, working with both Congress and the administration. He was the former DHHS Assistant Secretary for Planning and Evaluation. He's a numbers guy, and we are going to get some data from him. He co-authored a report funded by the Robert Wood Johnson Foundation entitled Assessing the Economics of Obesity and Obesity Interventions. Dr. O'Grady?
Good morning, and thank you very much for having me here today. I would like to talk about, to a certain degree, I'd like to talk about obesity, but much of my talk will be about this intersection between obesity and the economics of it, and the costs involved, and different ways you can approach it, where you look at the spending involved in obesity. So, as I think most of us know, currently our healthcare system is under a lot of pressure in terms of being more efficient with how it spends and being careful, and it's an important policy area where it's tending to crowd out, especially at the state level, things like elementary and secondary education, areas that we really don't want to. So we want to have the most effective intervention clinically, at the same time being sort of smart about how we finance that and how we do that. So I want to give you some of the background there, and then some of the different interventions that my co-author and I were able to find that actually met some of these criterias. Okay. This first slide is just giving you the background in terms of thinking about obesity and how it's changed over the last few decades. So this starts in 1961. So we're giving you 40, 50 years range here. So you can see the bottom section there that really hasn't changed very much is the overweight population. So that's been roughly around 30% or so of the population pretty much since the 1960s. But then as you move into people who are obese and then people who are extremely obese, you start to see this is where this momentum is coming from, and it's a pretty negative momentum. So you can see the number of people who were simply obese was around 13% in the 60s. It's about 3 times that now. Extremely obese has gone from about 1% to about 6%, so it's 6 times what it was in the 1960s. So that's where the real growth rate is, not in a good sense growth rate. Now this is to give you, this is a new study that was done, came out this, next slide please, in the spring. And this was by a group of a team of British and American researchers who were trying to project and say, well, what does this mean? We've seen what this trend is over the last 40 or 50 years. Where is it going from here? And so these lines are giving you men and women, and they're using both a pessimistic and an optimistic assumption, which is pretty common in policy. You'll see that, where they're saying, we don't really know, so let's do sort of a worst case scenario, best case scenario. And that's what they're doing here. And as you can see, it makes very little difference if some of those lines get very close together. That's the men. really, whether positive, that is sort of a trajectory that's moving up at a certain rate. It's not really that, it's not moving around very much. But the women, there is this stance. So what they found is, what these researchers did is they said, well, we know what the trend's been over the last 40 years or so, but let's just take a look at the last decade or so. And so women have done better at slowing the rate of obesity, not continuing to grow. So if American women can continue to slow, it's still growing, but it's at a slower rate, it's a lower percentage, they can have a much better trajectory, and better than the men, which is up to this point you can see is sort of not been necessarily the case. So next slide, please. Okay, there's often this discussion, and I don't want to take a long time about it, but there's this discussion about Americans and, have the biggest obesity problem, and we do, there's no doubt about it. But there was a study I saw, it was presented in Paris at what's called the Organization for Economic Cooperation and Development, and it's the major countries, US, Japan, France, Germany, et cetera, et cetera. And the fella, he was an Irishman, a real Irishman, not an Irish American like me, he was presenting it, and he was saying, we see this in the US, the UK, and Australia have the biggest obesity problems. And so our conclusion here is speaking English is highly correlated with being obese. And then he said, so I said he was an Irishman, right? So a little bit of a smart ass there, right? So then he goes to, and and the French are all and the Germans are all feeling pretty good about themselves. And then he said, but then the other thing we realized is there's only 3 countries out of the 22 countries that were in this who actually, a neutral third party weighs the person, rather than just asking people on a survey whether they're obese or not. And those 3 countries are the United States, the UK, and Australia. So this shows you a little bit of kind of how that effect is. So I hope you can see it, but there's a point where you're seeing Canada in there. And Canada is one of the survey countries, except one year they actually had nurses measure and do this. And you can see there, that's why this jumps up by about 17%. So it's a little, and the Canadians are right there in between the English and the Americans and whatnot, so I'm sorry if any of you are Canadians, but it's not, you're not off the hook here either. It's just, part of that is kind of how you measure obesity that can get important in this, to know how big a problem you really have. Okay, now this, next slide please. So this starts to give you a feel. I said I would talk about kind of what this costs, what the economics do, and what this is spending, how this affects. So what I'm trying to give you here is an idea of what percentage increase in regular kind of spending that we see out there do you see because of obesity? And this is sort of, they've decomposed it. This is not my study, this is another study. And they've done it by Medicare, Medicaid, commercial, which is really employer insurance, you can think of for the most part, and then the total effect. And they break it out by hospital, what they call non-inpatient, which is both outpatient at the hospital and in a doctor's office, prescription drugs, and then they give you the total. So you can, in some areas, and this I thought was a pretty clean analysis, some areas there's nothing. So in the Medicare population and inpatient, that that just means it's not statistically significant. It's not significantly different spending going on for the obese population than not at least in percentage terms. We're going to look in a second at it in dollar terms. But you can see that in the Medicare population, it has some effect, mostly on the prescription drugs. If you move over to the Medicaid population, not really on hospital, not even really on doctor visits, but it does in the prescription drugs. And there's enough in that it actually has a pretty big effect on total. If you move over to the commercial, that's where you see the big effect. Because this is something where people are having symptoms, they're needing procedures, they're needing drugs that typically you wouldn't need until you were over 65, and they're needing them much younger. Because it's in effect having that kind of I don't want to say an aging effect, but it's sort of things like the diabetes. Things you might naturally have hit at some point when you turn 75, you're getting it at 55. Those sorts of things are going on here. And so you can see it has a big effect on all kinds of aspects of spending, particularly again in terms of on the drug side, but it is sort of this overall. Now I'll quickly move to the next one. And this just gives you how these things add up in terms of total dollars. So I'm going to ask you to not read a chart like most of us read a chart, which is left to right. Just go all the way to the right. So we're going to pretend we're reading a Hebrew chart. We're going to start on the other side and we're going to move back. And so the main takeaway here is, because you already saw how this affected as a percentage. So you can see that it says, but this is $146.6 billion a year. So this is not, you could do, an awful lot in terms of good if you had an extra $147 billion every year to spend on healthcare. That would do a lot of either other things in healthcare or an awful lot of things in elementary and secondary education or a lot of other fundings. So it is a major economic impact in terms of what's going on, as well as a horrible kind of health impact for the people involved. Okay, I'll go quickly over this, but this is to give you, this was an estimate done, again, on the idea of what happens if the current trends continue, or they slightly deviate either better or worse for us. This was done by the Congressional Budget Office, and for those of you who know DC, those are sort of the official umpires of what things tend to cost when you talk about public policy, changes in Medicare and Medicaid, et cetera. And so you can see they've done 3 scenarios here, where it is, and I'm sorry, I'm having a little trouble reading my own chart here. Body weight, if it continues unchanged from the 2007 rates. And that's where you've got a rate of about 28% of people, 65% of spending on the effect. If it gets worse, which is scenario 2, you can see it goes up to 71. If we're able to turn this around, you can turn that and make it 59. So this is a fixable problem. There's no doubt about it. It's a fixable problem that has horrible outcomes for the individuals involved and horrible outcomes for the system in terms of spending. I'd like to turn to the next slide, please. So this, when we think about, now to turn to kind of, okay, what can we do? What are the interventions? And my job in terms of this study was to go through and to try and find what were the, only stick to the things that work medically. I mean, there's no point in kind of evaluating the economics of things that don't work. And then take a look and see what were the most, what is called cost-effective, and then also what is considered cost savings. And I'm going to talk a little bit about that more. But right now, when you look at typical, there are 3 new interventions, or 3, maybe drugs, it may be a protocol of how to treat patients, it may be a medical device, and there's 3 out there. They've all been cleared by the FDA. They're ready to go. Typically, it's looked at who is the most clinically effective, and we'll go with that. Now, not that that isn't the same calculation. Next slide, please. Now you're going to sort of think about, well, what do they cost? I'm afraid the reality of where we've gone with, when you hear Medicare trust funds running out of money, is it used to be a decade or 2 ago, we could sort of do things and costs were sort of in the back of mind, but not in the front. It was sort of, and so we've sort of run out of that leeway, if you want to think of it that way, that we now have to take this into account. And so if you take a look at the next slide, you can see that was a simpler, sure, let's do A. Now you're all of a sudden, A can be much, much, much more expensive than B. And C is the one that actually saves money. Now, we don't expect everything to save money. If you go and you have a bypass operation, $35,000 is for the we don't expect to get a return on investment from that. I mean, you're healthier. That's the return on investment. We don't expect that you're sort of going to turn around necessarily and save money on that. But there's more and more of a pressure to look at new things that will actually not only not be as expensive as the last generation, but actually can start to at least be more careful with the spending, if not actually go so far as saving money. So when I said that there's these 2 logics out there, and you will hear them sometimes in debates used interchangeably, and they're not. Cost effective means that something does cost more, but it's of good value. So, and typically what that's done is it's done in a way where they talk about, and it gets a little gobbledygook, I have to admit, it's referred to as a quality adjusted life year. So back in the 70s, we went ahead and we moved forward and we decided we were going to cover under Medicare people on dialysis. And so what that cost of that, it was basically about $40,000, $50,000 per year to give them one more good year, not in the ICU full of tubes, but a good year. So of course what happened not in a medical sense, but in a policy sense is, of course, then the cancer guys came in and said, well, if you were willing to spend $40,000, $50,000 more a year on the kidney dialysis people, you've set a policy now. Won't you spend that on cancer? Then the diabetes people come in. Then and so this is an attempt of saying, for how much more would it cost to provide this person one more good year of life? And so that's where it's at that point. It was starting at around $40,000, $50,000. Now, insurance companies, the government doesn't use this. Insurance companies use it. It's around $100,000. So it's not expected to save money, but it's not expected to cost more than $100,000 to give the patient one more good year of life. So B would probably be cost effective. C is cost savings. So next slide, please. So as we move into this is these next 2 or 3 slides. I'm just going to run through for you a little bit, and I hope It's readable. The font's getting a little small there. I apologize for that. So we're in a situation where we took obesity interventions cover a wide range of things. There's school-based interventions, there's community-based interventions, there's pharmacological, there's medicines for obesity, not a ton, not that they're not, hitting home runs. And then there's also bariatric surgery. So it's unusual for a particular thing to have this broad a range of from school-based all the way to surgery. But we took a look through hundreds of different ones, and we narrowed it down to the ones that were clearly cost-effective. So you'll see in the school-based there was a couple that we found there that was pretty good, what's called the CATCH program. And I won't go into detail because I'm going to eat up the other speaker's time if I do this, but you can see, yes, were we able to find at least 2 programs that had a nice, rigorous evaluation of them and found that they met these criteria of being cost-effective, if not saving. As we moved into community-based programs, you see many of these things, Wheeling and Walk, you see these are very nice. This is a lot of YMCA, Weight Watchers, some of those kinds of interventions, and we found a number of them that, again, did they cost? Yes, $28,000, $27,000, but they did deliver the clinical outcomes you were looking for, and it was within that criteria of still being a reasonable value for what you were spending. Next slide, please. So this is just continuing. If you have this presentation, you can sort of go through this. Like I say, I'm a little concerned I'm running into my colleague's time. The only things that we found 2 things. Now as we move into, next slide, please. Pharmaceutical interventions, we found 1. But some of this stuff, they just have to start to test these things and evaluate them to see whether they would meet these criteria. The one that we clearly found was, you can see down there where I've done a little highlighter there. This is a bypass operation. And this highlights, this is a cost saver for people who are extremely obese. Body mass index over 50, which is a big person, no doubt about it. And that little, it says ORD cost. Those are people who already have what's called obesity-related disease. So if you spend $30,000 to $50,000 on a bypass operation, you do save money there because that person is going to cost you clearly so much money over the next 5 or 10 years that that's a drop in the bucket. And so if you can spend 30 to 50 and save 100, you've actually saved money here. Now, this highlights one of the things that's important in this area. As you think about how you would come up with an effective way to combat obesity, this is a surgical situation. Surgeons and many medical providers look at the world a little differently than the YMCA and Weight Watchers do. This is a targeted approach. They've already looked at what they can, considered an ideal candidate for this intervention. You go in, so you're not spending a lot of money on people who are never going to have this problem in the future anyway. And that's normally how the president got embarrassed after he made a number of speeches about how prevention would save money, and then those pains at the congressional budget offices said, well, we haven't really seen it. It's a good thing to do, everybody walking, it's a good thing to do, but it's not saving money. This one actually saved money. The other one, which we can talk about, is, next slide, please. And they look at it a little differently, when we go into workplace interventions, you can see there that in terms of this study found, and the first line there, this is looking over a range of what employers are doing, but they found basically a $3.27 drop in medical expenses for every dollar spent. So that, again, employers tend to look at this as return on investment. They don't talk about quality adjusted life years. So you change your measure to meet your audience. But these were found also to be cost savings. So again, it's that idea of, can you pick this out? Can you design these? It's not like they're all equal. Some are kind of more shotgun. They're not focused on people who you think are really going to end up with trouble. But if you're trying to get to something that actually will, if you want to go for that higher bar of you're going to do it, you're going to spend some money, but you'll actually save money, this notion of really being careful how you target the intervention. And so the YMCA bringing everybody in and we all walk 10 miles together is a great thing for our health, but it's not going to save money. Okay, and that's my presentation. Thank you.
Everybody in this room knows that if you understand the money, you got a better chance of winning. Dr. O'Grady, that was fabulous. Thank you so much. Now, our next speaker is going to join us via Skype. God, I hope somebody can work that machine. I'm looking at you, Lizette. Oh, thank God. Kathy, hi. So anyway, Dr. Spong, for over a decade, she's been chief of the pregnancy and perinatology branch at the NIH. Just this week, she was appointed director of the Division of Extramural Research at the NICHD, which is part of the NIH, a budget of $1.1 billion, staff of 130 individuals with 3,100 research projects. She is nationally and internationally recognized as a superstar in maternal health, and we are so fortunate to have her here. Kathy?
Hi everyone, can you hear me okay? Wonderful. I want to thank you so much. It's absolutely delightful to be here. I want to thank Ms. Thompson and Dr. Rice for inviting me and the Wisconsin Women's Health Foundation. I'm so excited to participate in the dialogue today, and the topic I was asked to speak on is that of obesity in women. Next slide, please. I don't have any conflicts of interest related to this presentation or any financial relationships with any commercial interest relative to this presentation. I work for the federal government. We aren't allowed to have any. I wanted to talk a little bit about obesity, and I thought it was kind of interesting. If you look at sizes of food, just simply sizes of food, over decades ago, in 1954 versus 2004, you can see that the hamburger we used to eat and feel was appropriate is a little bit different than the hamburger we choose today. And French fries, my children wouldn't at all be interested in that little tiny thing of fries on the left. They much prefer the larger thing of fries. And if this is what we're presenting people, it's not a small wonder that obesity is a problem for women, for our children, and for our families. Next slide, please. So just simply, what is obesity? Well, obesity obviously is excessive body fat. There's lots of different ways to measure obesity. Probably the most common is that of the body mass index, which I'll go over in the next slide. But there's also, you can look at body circumference, you can look at waist to hip ratios, lots of different ways to try to understand what is that impact of obesity and how should we best measure it. Next slide, please. There is an online BMI calculator that many people use, especially clinicians, when we see patients, that I think can be very, very helpful and very telling to let patients understand where they fall on the spectrum. It looks at your weight in kilograms or your height in meters, or of course there's converters for those of us who never measure anything in a meter. Those who are overweight have a BMI of over 25 and just under 30, and those who are obese have a BMI of greater than 30. And then, unfortunately, we've had to actually do further classifications of obesity, getting to obesity class 1, class 2, and class 3. And it is not uncommon when you see a patient that they are actually in the class 2 or class 3. Next slide, please. Hopefully I can get to the next slide too on mine. So obesity is the fastest growing cause of disease and death in the United States. Pretty impressively, over 60% of U.S. adult women are overweight, and over 1/3 of overweight adult women are actually obese. The World Bank has estimated that the cost of obesity in the United States is about 12% of the national health care budget. Next slide. I'm an obstetrician gynecologist with subspecialty training in maternal fetal medicine, so my special interest is going to be the reproductive age women, and 30% of reproductive age women are obese. And an additional 25% on top of that are overweight. There has been a 70% increase in the proportion of women who are obese at the beginning of pregnancy. And as you will hear later in this program, the implications of obesity in pregnancy are huge. Next slide, please. So at the National Institutes of Health, we obviously are very interested in major public health issues, and obesity is absolutely one of the major public health issues we have in the United States. 34 million Americans are overweight, and it's increased from 1 in 8 in 1991 to 1 in 5 in 1998 that are obese, and women are at increased risk. The racial distribution is different. 45% of Black women, 35% of Hispanic women, 25% of white women, and 45% of American women are obese. Next slide, please. These next series of slides are going to show maps that many of you have seen. This is not new information, but it is startling as you go through it. And it looks each year at the obesity trends in the U.S. adult population. And blue, you would think was bad, right? That's dark blue, meaning the obese people, 15 to 19% in that state are obese. And this is in 1996. And if we click through to the next slide of 1997, you can start to see actually blue isn't as bad. You get to that light tan where it's over 20%. 1998, more over 20%. 1999, almost half, 20% adults are obese. In 2000, it grows even larger, and oh dear, click again for 2001. We're actually moving now to a new color, that of a reddish color, where over 25% of adults in that state are obese. 2002, we now have 4 states in 2003, just keep clicking ahead. 2004, a significant number of states have over 25% of their U.S. adults being obese. 2005, we need to add another color because now we hit to over 30% of that population in that state of the adults being obese. And in 2006, 2007, 2008, again, more states including over 30% adults are obese, and very few states now, in fact only one, still is blue, and it's that dark blue, that 15 to 19%, which was initially concerning back in 1996. 2009, we still have our one blue state and more, over 30% obese in the United States. 2010, we get rid of that blue state. It's gone. The next slide shows that this isn't just a problem in the adult population. This is also a problem for our children. And certainly we see this in schools today. It may be in part due to lifestyle factors, right? We now have computers that I didn't have as a child. I went outside and played. We now have computers and computer games that we've actually configured to try to get the kids to be fit, right? So they play a computer game to get fit. At least my child does. He tells me, but Mom, I'm playing Wii Fit. It's okay. I say, well, maybe that's better than just playing Super Mario, but perhaps it would be good to actually go outside. So this slide looks from 1963 and 70 on the far left to 1999 to 2002 on the far right. And the children aged 6 to 11 are in the light blue, and those who are aged 12 to 19 are in the dark blue. And you can see that the prevalence of overweight children and adolescents has dramatically increased from less than 5% back in the 1960s to over 15% in 1999 and 2002. So it's not just a problem for our adult population. This is a problem for our children. And of course, that's going to have a huge impact lifelong for them from the medical conditions and problems associated with obesity, especially that of obesity starting as a child. Next slide, please. The morbidity of obesity, I couldn't even fit all on one slide, so I just kind of picked and chose those that I thought were most important. But obesity causes so many complications and so many problems in medicine: hypertension, diabetes, hyperlipidemia, heart disease, cancers, endometrial cancer, breast cancer, obesity, colon cancer are all associated with obesity. Degenerative joint disease, gout, gallstone, and kidney disease, gastric reflux and sleep apnea, surgical risks, depression, all associated with obesity, and all increase as rates of obesity increase. Next slide, please. Importantly, I think for this conference as well, is that the morbidity of obesity includes not only regular medical conditions, but also has gynecologic implications and obstetric implications. Now, I'm not talking about the obstetric implications because I know they're going to be really well covered in the next presentation. But gynecologic complications include infertility and menstrual irregularities, ovulation problems, reproductive cancers, as I already mentioned, as well as metabolic syndrome. And for those patients who are obese and infertile, once you get them pregnant, As you will hear in the next presentation, there are many, many complications in pregnancy as well. Next slide, please. As we look over time at mortality rates, and if we look at two very, very common things, smoking, which is highlighted in blue, and obesity, which is highlighted in red, you can see that, in fact, obesity has overtaken that of smoking in the risks for mortality. So as obesity rates increase, they're contributing more and more to mortality, as you would expect, given all of the complications associated with obesity. Next slide, please. Now, it's not all bad news. Clearly, if we can improve our weight and allow for weight reduction, you can have significant improvements in medical outcomes. A weight reduction of even just 5 to 7%, which isn't a huge reduction, is associated with lowering blood pressure, improving cholesterol, and lowering the risk of developing diabetes. But I think, as was mentioned earlier and is going to likely be mentioned much more in this conference, that treatment is going to need to be done in a multidisciplinary fashion. And it has to be culturally appropriate. And it has to have a specific approach, just like we have specific approaches for all of our chronic diseases. We have algorithms for hypertension. We have algorithms for how we treat diabetes. We need to have those for how we improve obesity rates. And we need to really focus on prevention, especially at these critical time points in childhood, in pregnancy, and at the time of menopause. Next slide. So in order to keep us on time, I kept this very, very concise. Obesity rates are rising. That's of no surprise to anyone. They are clearly reaching concerning levels in both women and in children. The impact on women's health is dramatic and includes an impact on reproductive health as well as a long-term impact, not only to mention the impact of obesity in children and that long-term impact not only for their reproductive health, but also for their long-term health. Some of this is going to be a role of technology and due to a role of lifestyle, and some is simply going to need to be a change in our thinking of how we should eat and how we should work and how we should play. Clearly, obesity is a very complex health issue, and our solutions are going to require diverse perspectives. Next slide. As Laurel mentioned, I work at the National Institute of Child Health and Human Development. Our goal is to improve health outcomes. Our goal is healthy mothers, healthy children, healthy families. I appreciate the opportunity to speak with you today, and I look forward to participating in the panel discussion. Thank you again for allowing me to participate via Skype.
That was fabulous. So the next speaker is going to focus on the impact of obesity during the perinatal period, and it is with great pleasure that I introduce Dr. Chanel Tyler. I first met Chanel about 6 years ago when she was a fellow in maternal fetal health at the University of Wisconsin, and it has been a pleasure to watch her star rise in the last 5 years. I'm certain that I will be working for her soon. Now, not only is she a fabulous doctor, teacher, but she's also getting her PhD in basic science research. Dr. Tyler?
Good morning, everyone. I want to thank the Foundation for inviting me to speak today. I'm incredibly passionate about obesity, especially in pregnancy. But I want to make a quick mention, a lot of the speakers have, that obesity is a lifelong problem for women. It starts early, as Dr. Spong just said, with menstrual irregularities in the adolescent years. You go on to have infertility and require infertility medications, which if you would just lose a little weight, which is a very touchy subject, you could potentially regulate your own menstrual cycles and not have to go through those types of treatments. And then you go on to have complications of pregnancy, which could lead to complication for your child's health. And then later on, you get to meet Dr. Rice when you have complications of your gynecologic cancers. So this is a very important topic that will expand the entire lifetime of a woman. First slide, please. I put this first slide up because I want to touch on the fact that obesity is a very touchy situation for women. We don't like to talk about it. No one wants to know what your weight is. You'd never ask a woman what her weight is. And that kind of happens in the doctor's office as well. It's really hard for us to actually come up with a way to address women about their weight. And so sometimes it goes unspoken, and that leads us to never really addressing the problem. But we have to, because it is more than just a clothing issue. It actually is a serious medical condition. Next slide. As Dr. Spong said, over 23 million women adult women in the United States are obese. That's a third of the adult women. She did a breakdown of the race perspectives of obesity and their impact. It accounts for 18% of obstetric cases of maternal death. That's a large number of women, and it should not be that way. 80% of all anesthesia-related maternal mortality is also related to obesity, and that's a scary, scary thought. Next slide. This slide on the y-axis is actually the percentages, and on the x-axis is the years starting in 2001 and going through 2008. And as you can see, we're looking at the rate of women of childbearing age entering their prenatal care in the overweight or obese category, and it's steadily rising, and in 2008 it was almost 40%. Next slide. Maternal obesity will lead you to multiple complications, and I can't focus all of them in the short period of time that we have today, and so I'm going to just briefly touch on several of them. But of most concern is gestational diabetes that you're at increased risk for, but not only are you at increased risk of developing diabetes during your pregnancy, and lots of women like to think that that's okay because it'll go away when I'm not pregnant. But you also are at risk of developing type 2 diabetes lifelong, and at a rate twofold that of the rest of the population. Increased gestational hypertension, so blood pressure difficulties, which also could lead to lifelong hypertension. Next slide. Increased risk of preeclampsia, and this is a disease that's unique to pregnancy. It's hypertension along with protein in your urine can lead to seizures and maternal death. It's one of the leading causes of maternal death worldwide. You can also have increased rates of large for gestational age babies. So when you think about birth trauma to babies, shoulder dystocia, operative deliveries, this all increases with your rate of obesity. There was some discussion earlier that there was small for gestational age infants, meaning your babies were not growing as well, but that has been found not to be statistically significant, and so I just put that in there in case you've read it. And there is also an increased risk of antepartum stillbirth, meaning you don't actually get to take your baby home, which a lot of women don't think about. That's almost threefold above the rest of the population just because you're obese. Next slide. There are also increased risks of developing blood clots, infections of the uterine lining, bleeding after delivery, prolonged hospitalizations, if you do have C-sections, infections in your wound, and dehiscence, meaning that the wound opens up. Next slide. There are also increased risks of anatomic defects for your baby. We've seen increases of about 7% in neural tube defect in obese women. Next slide. It's also more difficult. A lot of women say, well, okay, you'll still find it on ultrasound. Everybody likes to rely on ultrasound. But if you think about the increase in obesity, I can only do so much with technology. That sound wave has to penetrate the amount of fat that you have. So my rates of visualization in ultrasound dramatically are decreased by the amount of weight of which a woman comes into our office. If you are less than the 10th percentile in your BMI, I can see about 90% of all of the fetal organs. Once you start increasing your BMI, you decrease my ability to see your baby's organ development by almost 63%. On the left-hand panel, you'll see the different organ systems, the heart, umbilical cord, diaphragm, and kidneys, and this is just a sampling. But the rates of my inability to complete that exam go up drastically just because of obesity, up to 50% for a heart. No woman wants me to tell her that her baby has a heart defect, but no woman wants to find out on the day of delivery either. Next slide. There are increased risks of post-term delivery, meaning you don't go into labor on your own. As a result, I therefore have to induce you. Next slide. Increased induction rates lead me to increased rates of operative deliveries. That's forceps or vacuums. This can lead to increased rates of vaginal tears and lacerations that need repair. There are increased rates of C-section. Those can be as high as 50% in the obese population. Next slide. The national rate of C-sections has gone up overall, and we have been actively trying to decrease that and actively encouraging women to have what we call a trial of labor after cesarean section. We like abbreviations, so TOLAC. And if you were successful, you'll have a VBAC, which is a vaginal birth after cesarean section. It's just a lot to write, so we like to cut it down. But your success rate of a VBAC in the massively obese is as low as 15%. And 50% of the patients who are successful in their VBACs, they have complications of infection. And that's the endometritis that we talked about a little earlier that then needs to be treated and can prolong your hospital stay. So this is not a come into the hospital, have your perfect delivery, and just go home that most women dream of. Next slide. No one thinks about it, but it's hard to get a blood pressure. I can't monitor your blood pressure, and I just finished telling you that hypertension is one of your big risk factors for being obese. Blood pressure cuff sizes, it's hard, they don't make them that big. Sometimes I'm using thigh cuffs. How accurate is that? Am I providing the best care for you, and I can't really tell what your blood pressure is? Reduced functional residual capacity, that comes into play for anesthesia when they're trying to ventilate you. It's hard for them to raise your chest when your cavity has so much fat on it. They're manually doing this. Sleep apnea, it's hard to keep you breathing. I have to give you narcotics. Anytime I slow that down, it's difficult. Increased reflux, we talked about this. There's a lot of reflux going on, more medications. And autocaval compression, again, circulation. How do I get all your blood flowing and monitor circulation when I have to put you on your back in the OR for the increased rate of C-section? Next slide. On your right, there's a 120 kilo patient. On the left, there's a 150 kilo patient. That's not all that uncommon in the state of Wisconsin. On the left, she's 300 pounds. That's pretty common for us. I don't think of that as out of my ordinary day. That's a lot of weight to put on your aorta and vena cava. And we have to tilt you to your left. And then think of anesthesia having to ventilate you and make sure you're breathing if you get into trouble. My instruments may need to be longer. It's a difficult surgery. I may or may not be able to see any bleeding if there's complications. It's dangerous, and no one thinks about it because we do it every day, and we let women be awake during C-sections. Next slide. Women want anesthesia. They want epidurals. They don't want the pain of labor. I get it. I don't blame them. I don't like pain either. But how does anesthesia find their landmarks to place the epidural? They need to be able to palpate your spine. They can't do it. That's why I put that picture up. Saying it doesn't show you as well as that picture. Just getting an IV in, can't feel your veins. I need access. What do I do? Puts a strain on the healthcare system, delays the OR. Next slide. You desat faster if they need to intubate you. It's harder for anesthesia to do that. They don't have as much luxury in terms of how quickly they have to get that tube in before you get in trouble. The reflux causes anesthesia problem as well. It's harder to intubate you. There's swelling in all the tissues in your throat. It's harder to ventilate you, the rise and fall of your chest. It's heavier. It's also hard when they get into trouble. What do? They put in a tracheostomy. Well, that's not so easy in all those tissues in an obese woman. Next slide. We talked a lot about the woman who comes in who's already overweight. But excess weight gain during pregnancy is just as bad. It can cause health impacts for long-term health impacts for women. There's postpartum weight retention, long-term weight gain, and excess body fat, sleep apnea again, diabetes again, coronary heart disease. All of these are problems in an area that is not well studied at this time. Next slide. What does it do for your babies? APGAR scores are lower at the 5-minute level. You can have neonatal seizures, low blood sugars, large babies, again with birth trauma, ICU admissions for the babies. And then there's a 4-fold increased lifetime lifetime risk of obesity in these babies. No woman wants to be the reason that her baby is overweight. It's a powerful tool to help her lose some weight ahead of time. Lifelong elevated risk of diabetes, hypertension, cardiovascular disease, cancer, and early death in these babies. We need to do something about it quickly. Next slide. We discussed this a little bit. I'm going to skip this in this effort of saving time for the next speaker. And hit on breastfeeding. Breastfeeding is a powerful tool. There are huge benefits for both mom and baby. You can decrease the risk of developing breast cancer and as well as ovarian cancer. You can decrease the rate of type 2 diabetes. It helps us regain uterine tone, which decreases your postpartum bleeding. It also temporarily suppresses ovulation, which in other countries that don't have as many options for birth control is a wonderful way to aid the spacing of children. Next slide. For babies, we decrease all rates of infection in regards to ear and respiratory. You decrease some of the skin conditions such as atopic dermatitis, some colon issues such as necrotizing enterocolitis, which is perforations in the bowel, and type 2 diabetes, as well as sudden infant death syndrome. So there is hope, and we just need to address it early, I'd say, before they get pregnant. Thank you.
Ooh, that was breathtaking. Yikes. So our next speaker is going to deal with social and family issues, socioeconomic and environmental factors related to obesity. Ms. Michelle Reimer got her BA at the University of Wisconsin. Presently, she's the director of the Solomez Institute of Obesity at Lenoir-Rhyne University in Hickory, North Carolina. She's developed a fabulous training program there. Now, not only does she have her bachelor's degree, but she also has her master's of public health and master's of nutrition from the University of Tennessee. She's got greater than 15 years of experience of working in communities dealing with this obesity problem. Michelle?
Well, I am so excited to be here today, coming from North Carolina up to Wisconsin. People down there think I'm crazy, but I always say I really miss Wisconsin. I miss the snow. I love Madison. So any chance to be here, thank you to the Wisconsin Women's Health Foundation to be back here in I guess, my homeland. I said the promised land last night once I landed and saw all the lakes and everything. So what I'd like to do today is to talk more, Dr. Tyler talked about some of the implications of obesity during pregnancy, and then touched a little bit on breastfeeding and its impact on obesity rates. What I want to look at more is really draw on my experiences from a weight management program that we have on the campus at Lenoir-Rhyne University, where we integrate curriculum from all different types of studies, from nursing to health and exercise science students, counseling, athletic training, occupational therapy, and then our dietetic internship program that is the only program in the United States with a concentration on child and adolescent weight management. So the things that I'm going to be presenting to you are really drawing upon those experiences that I have in the integration of that curriculum, working with lots of different professionals, that interdisciplinary approach that you talked about, and then also working with my actual clients that we have in the clinic. So again, we'll look at the socioeconomic impact of obesity, environmental factors, weight. We'll talk more in depth about the weight management program and really why it's important to work with that entire family unit. And then finally, what I'm really passionate about is the woman's role, the unique role that we play in obesity prevention and impacting the quality of life of our future generation. So I'd like to show this slide because, as Dr. Rice said earlier, is really childhood obesity in general is an extremely complex issue. And I would argue that maybe it's not necessarily even an obesity epidemic, but an epidemic of poor nutrition and inactivity. But this framework from the Institute of Medicine really gives you a great visual of how complex the issue is and how we really need all these different people, everyone in this room, so many different professionals to attack it at all different levels to really help to control and to prevent in the future. So I'm going to look really a lot at that behavioral setting in the coming up slides. But again, all of these issues are extremely important in prevention and treatment. Next slide. I like to start looking at the socioeconomic status because most of the clients I have in my clinic and our program are low income, living in poverty or just above the poverty line. And so I love visuals of maps, and if you look down in the Bible Belt area where I'm living now, it's been a very different experience for me, but you see that very dark, the dark red, greater than 30% of those people have obesity. And if I were to show you this chart with children as well, you would see very similar colors. So then if we go on to the next slide, and again, remembering where that dark color was specifically even in that Bible Belt area, and we look at the levels of poverty, you see that it's very consistent that they're in the areas where there is higher poverty levels, we also see higher levels of obesity. Next slide, please. So what is it specifically about the socioeconomics and obesity, but specific to women? So let's look at some of the things we know about women and poverty. Shockingly, in 2010, over 17 million women lived in poverty. And of these women, single mothers accounted for greater than 40% of those living in poverty. So if we're looking at the generational impact and the unique role that women play coming from a single family, we can say that half of our children that are living in poverty have mothers or are living in a single female-headed household. And then unfortunately, as we all know, with low income comes people living in areas where, one, they have fewer recreational opportunities, and we'll look a little bit more in depth in that in a couple slides later. And they also have reduced access to healthy food. So something that Susan may be speaking about or that we can talk about later is the whole idea of food deserts. And what are we doing to address that as a community as well? Next slide. So that was looking at women in poverty. What does poverty do to our rates of obesity? Well, we know that there's a strong association between lower incomes and poverty. So people with less money tend to have a higher BMI or body mass index. We also know that when someone is of lower income, they have less activity. So what does that do? We don't move as much. It increases our BMIs. And then also that low fruit and vegetable intake is also associated with a higher BMI. So if you're living in a food desert and you have limited access to fresh fruits and vegetables and healthy foods, then you're at higher risk just through that for being overweight or obese. Next slide. So let's look at some of those environmental factors, because I can get really excited about this. I would love to take you all on a walkability tour of even just the downtown Madison area and show you how just your built environment is has such a powerful impact just on your daily activity. So we look at some of the communities that are not bike or walk friendly. Hickory is a very un-bike friendly, walk friendly community, unfortunately. I look at Madison and I always tell people about how they have bike lanes and there's sidewalks everywhere. But I assure you that even in Madison, we can find a community or different neighborhoods where there are no sidewalks. Or perhaps maybe the stoplight to walk across the street doesn't allow someone that has several young children to get across the street in time before it says, nope, don't walk, and the cars are going to start coming. So this I would refer to as the whole idea of complete streets, and some of the campaigns that are out there that are really looking at how do you do urban planning when you look at communities and how to make them more accessible. There's also limited access to recreational facilities. Usually lower income neighborhoods, they may not have parks, or parks anyway that aren't, that look inviting to children to play. Maybe it's not a safe place. I have many of my clients that say their parents don't let them go outside when they're not home, because for safety reasons, and then also for reasons related to police and potentially immigration issues. The safety concerns I mentioned. And then the trend of less daily activity in schools. It's just dumbfounding to me to think about reducing the amount of physical activity in schools when we know that research says that kids need to move, kids need that kinetic activity to get their brain stimulated. And so we're focusing so much on these end-of-year exams and getting kids to test in math and science and reading, but we're not realizing that they're not going to learn those skills and tools just sitting there, sitting still, that they'll actually learn better being more active. So the family connection. We know that parent obesity is one of the strongest risk factors for childhood obesity. So if a child has one parent that's overweight or obese, some research has shown they have about a 50% increase in their risk of becoming overweight or obese. If both parents are overweight or obese, they have an 80 to 90% risk of becoming overweight or obese. And families, the parents, we provide genes, and we also, though, provide the environment in which those genes are expressed. So parenting style has been looked at. Parents that are more restrictive with eating, we might think that we are helping our children, don't eat that, don't eat too much. But actually those types of parenting styles have been associated with increased BMIs in children. We also look at the availability of the food. Who does most of the shopping? Moms a lot of the time do, at least in the families I work with. So what foods are available? What choices are you making available for your children at home? And then physical activity. What behavior are you modeling? Are you getting your kids out to play? I've had that conversation too with the she was speaking about last was, first of all, do you even let the Wii into your home? And then second of all, if you do, what's the lesser of two evils? The Wii Fit or the Mario Kart? So it's something that we need to think about in the environments that we create for our families. This is actually the picture up there. That's my daughter eating an apple, and I will tell you, she loves fruits and vegetables. In the next slide, I'll show you about my son. So Nora Kate is now 7, and we know through research that children's food preferences are more strongly correlated with that of their mother. So anytime my children want candy, I always kind of go, oh gosh, I should never have been drinking that huge cup of coffee and eating that half a bag of M&Ms on my way to work while I was pregnant. So, and I am a dietitian, mind you, but all foods fit, right? We also know that then just even my decisions that I make on a daily basis greatly impact that of what my daughter's going to make. So if I'm choosing lots of fruits and vegetables and lots of lean meats, things like that, those are the things that she's typically going to choose more. Also, unfortunately, as mothers, the role we play in our children developing their body image is incredible. So if I am more influenced on dieting and what I'm eating, my daughter is going to do that as well. And she is going to recognize what her body looks like, and she may do food restriction through just seeing what mama does. And then finally, there's this strong association between my weight, now, not even just during pregnancy, but in the current time, and the weight of my children. And this association has been shown very strongly between mother and children and their daughters. So, and I don't want to discount just moms, because I will say that all women play a role in the development of children. And I show you this because my mom, who's also a dietitian, and I said I'd never be one just like her, but so, you know, the first child, you're always really appropriate with what you give them. You don't let them watch TV till they're 2, and then you only feed them fruits and vegetables. Well, the second child, when grandma gets a hold of them, this is my son at one of the ice cream shops on State Street when we lived in Wisconsin still, and she gave him his first ice cream cone. He was delighted. So just about a month, not even a year ago, we were given some samples of drinkable, you know, those drinkable juice things. They're like applesauce. Well, this was his reaction to to drinking the applesauce. He looks as if he'd been violated and that I just completely have lost his trust. I have a picture of my daughter, and she drank the exact same thing, and she's going like this. Yeah, this was good. So I don't know if it was the apple she was eating in the last slide and then the ice cream, but grandmas play a role as well. Aunts, uncles, though too, grandpas. So go ahead to the next slide. So what do we do? What have we found are the best ways to work with our clients? Really, when you are working with a woman, counsel her as the family health leader. Empower her. Let her know that the things that she does, her behaviors, they empower the rest of the family. They model behaviors for her children. We actually focus on a family-based program where we include everyone in the family, but there's actually some really interesting research now that has shown that even just working with a parent can be just as effective as the family-based program. So if you can't get the entire family into your site to work with them, even working with the parent at the Y, in the schools, in the OBGYN office, that can be even more powerful than just trying to talk to the child about having a better weight management program. And so what are my takeaways for the mothers in our program? First of all, again, they are the health leader. They are modeling the behaviors for their children. Their children are watching them. It's kind of one of those, you know, we always say, do as I say, not as I do, but you want it to be do as I do, you know, do as I do and do as I do. Yes, I'm doing this. The second is, you can go on to the next, is to create opportunities for your child to make healthy food choices and activity. So create an equal opportunity environment where making food choices, healthy choices, is easy. We also focus on the Eat Smart, Move More campaign in North Carolina. We focus on some very simple things. We call it the 5-3-2-1 Almost None campaign. And we give out little prescription pads that check off which goal is going to be theirs. The 5 is 5 fruits and vegetables a day. The 3 is 3 balanced meals, so not skipping breakfast. It is the most important meal of the day. 2 is less than 2 hours of screen time a day, and I have clients that watch 8 hours of screen time a day when they're like 8 years old. It's phenomenal. It blows my mind. And then 1 is getting at least 1 hour of physical activity, and the almost none is almost no sugar sweetened beverages. And in the South, sweet tea is a huge thing. And I went to McDonald's when we first moved there, and all the kids were walking around with big sweet teas, and I thought, that's why everyone's so overweight, is all the sweetened beverages. And then finally, make it a family affair. Again, as women, we are those health leaders. We are bringing and developing future generations. So make sure that you get everyone involved, and I think that is our best advice to give to mothers. Thank you.
And I do want to add that I believe that Wisconsin is the promised land as well. I moved here from the Bible Belt in Virginia. I've been here about 5 years, and we do live in a fabulous place. So our final speaker is going to address the impact of obesity in Wisconsin communities. Susan Lattin is the Obesity Prevention Program Coordinator at the Wisconsin Department of Health Services in Madison. She's got greater than 20 years of experience leading community-based prevention initiatives in Wisconsin and nationally. She has supported Wisconsin community coalitions in their development of innovative policy, system, and environmental changes to improve access to healthy food and physical activity. Susan?
Good morning. And I want to thank the Wisconsin Women's Health Foundation for all the pioneering work that you've done to help improve the health of women, and the panelists inviting us to focus on, this very crucial issue here in Wisconsin. We've had, it is a little dark down here. We have gained a lot of insight today about the burden of obesity for our society as a whole and the debilitating impact on women in particular. And I thought maybe it might be time to just take a moment, if you would, grab your pen and a pencil and think about what a healthier community would look like to you. What's your vision for a moment about what it might look like to really create a healthier community where escalating obesity rates that we're experiencing could be slowed and reversed? Just make a note to yourself, and then we'll come back to it in a moment. I appreciated the opportunity to be briefly recognized as a registered dietitian as part of this project. However, the truth is I am not. In fact, I've gained about 15 pounds myself working on this obesity prevention project. So I have, very little nutritional guidance to offer you. But I have worked very closely with community coalitions around the state who are doing some amazing, hopeful work that I want to share with you today. So we can go to the next slide. This slide represents that pyramid of opportunities, another way from Michelle's of the opportunity we have to intervene and impact health. And the focus of our community work today is increasingly focused down on changing the context through the implementation of thoughtful public health policies. So if you think about our pregnant mother and overweight mother to be seen in the clinic there, and then referred to counseling and guidance there, but she's very likely to go home, as Michelle describes below, to a community that lacks access to both healthy, affordable food and safe places to be active. While all of these interventions are important, our community coalitions are increasingly focused on changing the context. So we use this social ecological model to help us understand why this young woman may have difficulty following her doctor's advice and what strategies might impact it. So this time, we followed our young mom home and we did an environmental assessment and found that while her neighborhood is, in fact, a food desert with only walking accessibility to fast food and convenience stores, we were able to connect her to a Saturday farmers market that will now accept EBT for food share benefits. She also reported that she has a part-time position at a healthcare facility that has adopted a new healthy food and beverage policy. And she is reporting that that has really helped her cut back on those sugar-sweetened beverages and junk food during the day. They're also considering offering an employee reimbursement program for an exercise program that she would like to take. So we see that connection between the formal and informal policies, both at organizations and communities, and how that might influence her individual behavior change. Next slide. So increasingly we are focusing, as Mike has directed us, on focusing on changes that affect many people with frequent exposure and in a comprehensive way. Our intervention settings you're all familiar with: early care and education, schools, communities, work sites, and healthcare. Our community coalitions are working in all those sectors. I thought today, with the little time that we have, as Michelle is directing us, I'm going to look at our work particularly with young children. There are 170,000 children in regulated care in Wisconsin, and those 6 and under spend an average of 30 hours in care outside the home. An additional 900,000 students spend half of their day in the school setting. Both provide really great opportunities to incorporate that increased physical activity and nutrition into every day to keep these kids on the road to healthy weight and good decision making. As I mentioned, we successfully brought the first obesity prevention funding into the state 2 years ago through a CDC-funded initiative called Communities Putting Prevention to Work. That work focused on early care in child care settings and in schools, helped develop and broaden a farm-to-school program, and also funded 2 communities that I've worked with closely, La Crosse and Wood. So a rural and small city example that really got to look at how they could marshal all the forces of the community, all the partners of the community to really change that obesity trajectory around. And I'm going to let them show you some of that work here.
Chef Thomas. Good job.
I'm the principal at Sand Lake Elementary School, and today for our farm to school, we had Chef Thomas from Gunderson Lutheran come and do a cooking show for our 4th and 5th grade students, and a lot of the vegetables that he used are ones that we use in our school lunch program as well. It's important for us because we're always looking at unique ways to introduce students to different vegetables and different recipes.
My name is Maggie Smith. I am a health educator with La Crosse County Health Department, and I coordinate the farm to school education. I kind of sent out blind feeler emails to all of these chefs. Hey, we have this idea, would you be interested? And that's how we found Chef Thomas. He replied and he was so excited. He thought this was a great idea, and he's been with us ever since.
It's kind of a passion of mine. I like to go to schools and educate the children on nutrition and how to eat better, and kind of a quest for fighting childhood obesity and in turn educating the adults. Anybody know what this vegetable is?
That's fine. Dope.
You know, some of the big winning points that we've learned, get the kids engaged. We take 2.
There is a website, I'll give you the link at the bottom at the end of my presentation, where you can see a number of different videos that have been produced for these communities, and they've really used it again as a mechanism within the community to help share their learning across the different sectors. So, and you'll see that really great collaboration in both communities between healthcare, public health, and other work sites. So that was La Crosse County, and now we'll hear a little bit from Wood.
My name is Christy Rauder, and I am the Community Health Improvement Planner here at the Wood County Health Department. Good Active is the brand that we're using for our obesity prevention program that we're doing here in Wood County. Everyone sees this as being a problem that we need to fix. We've been working in the schools, we've been working with work sites on increasing worksite wellness, and really just trying to change our community and approach the health aspect on a community level. The really big umbrella goals are to reduce this epidemic by increasing the amount of access that there is to healthy foods, and then also increasing the amount of time people spend being physically active,
working on increasing physical activity and nutrition.
In work sites, we're doing some things with vending.
Convert our vending machines into healthy foods.
Not traditionally what's in vending machines, so we're really trying to make a cultural shift about what's even available. The schools see it too. You know, they see that students need to be well, to perform well academically, and you know, they want their students to be healthy. And Farm to School has been a huge success. Fruits or vegetables are brought into the school, and we do taste tests with the students and getting the kids excited about it.
Getting a lot of really big beets.
We're also working with the schools to develop gardens.
It's a lot of fun. I have celery and a red pepper.
And to use their greenhouses if they have them.
A couple junior high classes that are using this hydroponics and help me set it up right now.
And then also we've got a Smart Meal program that we're working with local restaurants on.
The Smart Meal is based on the ingredients, on the calories, on the sodium, you know, what's going to be a healthier option.
Take a look at how can we revamp and keep that flavor that everybody's looking for, but make that healthier for everybody.
Jamaican Kitchens is one of our Smart Meal restaurants in Wood County, one of 7 so far. We know that people spend more than half of their food dollars out to eat, and so we work with the restaurants to have healthy options available to us. I do what I do because I believe fully in it, and I live it. It's a passion of mine.
So that's one thing that we're doing, and
I love to see communities come together to make change. And it's happening here in Wood County, and it's amazing what people can do when you all work together.
So there's one community vision that has been realized. A team of people came together, and we have, next slide. I'd like to kind of take you through a celebratory journey of a day of a young girl in Wood County who now gets up in the morning, and she and her dad have created a new routine where they actually make breakfast together. And a lot of times that breakfast includes fruits and vegetables that he now has access to through an employer-supported CSA purchase ability that is a brand new program in Wood County. It didn't exist before without that program. Then they quit driving Abby to work. Their mom, who's pregnant with her second child, never really was able to lose that first birth weight, needed to get some physical activity. They got together and organized a walking school bus program. So they both get 20 minutes or more of exercise a couple days a week. And Abby really loves having that extra time to hang out with her friends on the way to school. You already got to see a little bit of what her school environment looks like, the enormous changes. They've done away with a lot of the competitive foods in the schools, the vending machines, the soda machines, even the competitive foods that are around in the after-school activities within the school have all been improved. Then Abby heads off to Boys and Girls Club in the afternoon after school, where she gets even more physical activity because they've adopted a new curriculum similar to the one that Mike was talking about. They've also planted a vegetable garden. Wood County has planted over 19 child care gardens and 6 community gardens and greenhouses in every school in the school district. So she gets a lot of physical activity at the Boys and Girls Club as well. And then her mom picks her up. They package up a couple of those boxes of food from the Boys and Girls Club and actually deliver it to a neighborhood food pantry. So they are increasing the food supply for people in healthy food supply for a lot of folks in greater need in Wood County. So then as a special treat, they head to one of their favorite restaurants, which because and Abby actually pointed this out to her mother when they went to dine, and she said, well, pick anything off the children's meal menu. And Abby said, but Mom, none of these options on the children's menu are actually healthy options. And they thought, wow, there's this new Smart Meal program that actually gets restaurants to assess their menu options and provide healthy options and label them, called Smart Meal. So thanks to their suggestion to their favorite restaurant, Abby now has a healthy children's offering at their restaurant. So I didn't get a lot of chance to talk about La Crosse County. There's a lot, they have worked particularly in that right-hand column of beginning a walk to school day program and building out across the county to a safe routes to school program. And they've also been the first county in the state to actually pass complete streets policies. They just did a bike count and found over the 2 years their number of biking pedestrians, bikers has doubled over the 2 years because of the street improvements that they've made. So we're really trying to look at beginning at one organizational level and expanding to the whole community. How am I doing? A little over. Okay, so we've got about 50 coalitions operating throughout the state, with lots less funding than La Crosse and Wood, but they are eager to do more work. We've just received a successor grant called the Transformations Grant, and you'll see some of that